Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host today, Eric Lim, and this Premier Education is brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Sites of Care. It's great to be back again for what I think is going to be the fourth season of the Virtual Grand Rounds this year. And we're going to start off with Dr. Lennard Lee, who is an associate professor at the Center of Immuno-Oncology at Oxford University, and also a medical oncologist who's leading the country advancing with the cancer vaccines in general. And I'm going to leave it to you, Leonard, to let us know about what's happening and where we're going from here.
Thank you, Eric. I really appreciate it. And what an honor. I can't believe I've been allowed to start season 4 of the Brompton Virtual Grand Rounds, because who knew that it goes across to 3,000 people and across the world to Vietnam and countries like Cambodia who are streaming this too and learning from what we discover in the world. It's absolutely wonderful to have everyone join us today. And I'm hoping this will be a really interesting talk for you to start the year. It's called the Cancer Vaccine Advance, Lung Cancer Vaccines and Beyond. And it's absolutely a good time to talk about this because we're at the start of 2025. In terms of who I am, as Eric's kindly alluded to, I've got a number of different hats. I'm very, very lucky to work at the University of Oxford as associate professor, where we're allowed to pioneer scientific discoveries and big ideas which can change the world. I've also got a role as a training as a medical oncologist, where I work at Oxford University Hospitals. I'm medical director at the Ellison Institute of Technology, and I work as National Government Clinical Advisor to the Office for Life Sciences. So, I guess at the start of the year, we might start off by thinking about where we are as a nation and across the world, and have the next thought, which is about what did we learn about who we are and where do we want to be? You can probably think about this yourselves for a bit. And what I'd like to do is this talk is to try and tell you a story of what we could be and where we might be going. And I guess part of the key to knowing what could happen in terms of the future of medicine really does involve us understanding the foundations that everything is built on. Because we've all lived through a period of most amazing medical discovery. And let me just try and walk you through it. And these are some of the achievements which we've done in the UK and also from the Royal Brompton itself, which is a fantastic world-leading institution for lung and respiratory illnesses. If you look back maybe just 50 years, you can see that actually many discoveries were made on this shore from the UK, from the discovery of DNA from Watson and Crick. If you just 10 years forward, the Brompton was the first hospital which brought the world a cystic fibrosis clinic. Scan forward just 10 years, which is such a short space of time in the grand scheme of things. You've got children being born to people who never thought they could have children. And the first IVF child from anywhere around the world came in the north of England, in Oldham. And again, you just see the pace of medical and scientific discovery speed up, where Sir Jakob pioneered heart and lung transplant, again at the Brompton. And then looking at big achievements now, new technologies coming online. The 100,000 genome project was completed in the United Kingdom in 2018. Huge, major achievements, and no one could have potentially predicted this pace of achievements. But what is clear is that we tend to underpredict how quickly medicine can change and how quickly it can change lives. From the start of the genomic age, new ways of cystic fibrosis treatment, which making people live longer before, IVF, organ transplant, and the Genome Project, all within the space of just over, in everyone's lifetimes. And I guess you've got to take the broader picture now. Was there an image or idea in the last 5 years which changed the world again in terms of what can be achieved? I think there was. And I'm just going to put this picture up again. And I know that this is being streamed across the world at the moment, but actually everyone in the world has seen this picture. That picture. This is a picture which everyone thought was impossible. The idea that in 2020, you can develop a vaccine that could give us all our freedoms back and stop people dying from a global pandemic. This is a picture of Margaret Keenan within 12 months, led through efforts from the UK Vaccine Task Force to bring through new therapies, develop research. And what is amazing is that this is patient number one, the first patient treated outside the clinical trial, surrounded by NHS nurses in an NHS hospital, showing the whole world that actually, when you've got confidence and focus and experience, actually anything becomes possible. And again, we all lived through the period where we all got told, don't bet on this. This will take 5 years. Scientific discovery must take between 5 to 10 years to get through clinical trials to change patients' lives. This picture shows the world that this isn't possible, and actually we should be really rethinking what it means to have medical discovery, because the timescales can be much shorter than before. If you use new technologies, and I'll allude to this in more detail, things can happen in a much more streamlined before. The question is not if it's possible, the question is how often this will now be possible as we start into 2025 and as we start to accelerate scientific progress in the medical sphere. So this talk is about cancer vaccines. So I'm going to try and bring you all up to the same level again, and I'll fill you in terms of knowledge about where we are in terms of lung cancer. So taking a step back, do bear in mind that in terms of vaccines, there are many different types. There are the peptide vaccines, which is what we've always had. We've always had these, and they've done a lot, but actually we've not been shown. They're hard to design, they're slow to manufacture. But what the last 5 years has given us is brand new technologies. I'm just going to mention words that you've probably heard of, like a viral vaccine. The one you've probably heard of is Chadox. That was being used in small infectious diseases, but actually that came to the fore thanks to work by AstraZeneca in terms of taking the risk and doing this at a no-cost basis for the world. We had the Oxford AstraZeneca vaccine. And again, we must really acknowledge the most amazing work by Oxford University and AstraZeneca, because they did this at no profit for the world. And that touched billions of lives around the world. And the other type of vaccine you've also got here is RNA vaccines. So these are very, very simple vaccines compared to the previous two, and they just give a DNA template. And this template can be rapidly updated, whether it's an alpha strain of the pandemic, beta, or Omicron strain. And they're very easy to manufacture. And the whole world's got used to them. And the Pfizer vaccine or the Moderna ones are both RNA vaccines. So we've probably all had these in our lifetimes already, but these are the three broad types. But one thing to say is that when you think about these vaccines, Eric probably got the same as me, who probably got the same as the people in the MDTs down in India and Vietnam who are streaming this into MDTs. We all got the same mass-produced product. And that was how things were done in 2020. But the most amazing thing is that people realize you can manufacture these and update them very, very quickly, because you just change that little bit of the middle of that DNA template, which just says what the immune systems will recognize. And if you can switch from alpha strain to beta strain to Omicron strain, the question now becomes, can you update to put cancer epitopes in there so you could try and immunize people on cancer? And then that next idea, it completely just blows my mind, is can you then make personalized vaccines for that person based on the genetic changes in their cancer? A personalized vaccine. So if I play this back again, there is a future which is rapidly coming to humanity whereby not everyone has the same vaccine. A vaccine which could be derived against their cancer epitopes is now designed for their cancer, the genetic changes there, and based on their immune system. Sounds very science fiction, but let me walk you through why this is happening, how this is going through clinical trials, because it is absolutely fantastic. Personalized vaccines delivered for that cancers and the person's immune system. Complete game changer, but all based on the same mRNA technology. What does it require? Well, it really just requires 4 steps to get to this future. And this is really going very, very well in terms of research centres all around the UK and across the world. The first step is where all hospitals can already achieve. Can you get a sample from the patient out? Eric is one of the world's leading surgeons in this space, and he knows that he can get lung cancer out. The next step is to link this into tissue sequencing or genomic sequencing. This has been done by a few good centres around the world. We have the Genomic Medicine Service in the UK, which allows to be done for certain cancer types. But if you do this routinely, you are able to pick up the specific changes within a cancer which is driving it, making it abnormal and therefore potentially recognizable by the immune system. The next two bits are the small jumps which the research community is now making to make these personalized cancer vaccines. It involves a bit of AI. When I say a bit, AI is a tool which is now powering much of the scientific discovery across the leading centres like Oxford and also across the world. And it is able to identify at pace and at scale and learn from it the genetic changes which can be recognised by a patient's immune system. And the final bit is that if you can put a manufacturing platform there, you can then print off that single vial for that patient based on the genetic changes that that cancer have. This is a vision of where vaccine technology may start to link in with genomic technology and AI technology. Three major technologies coming together with the confidence of what was achieved in 2020 to change the future of cancer care. And this is an exciting time to be alive. I just love being a medical oncologist now, seeing this train coming and looking for the centres around the world to open. And it's fantastic to be able to champion this on behalf of the UK and getting this open, but this should happen across the world. We're very lucky. I count myself very lucky to live in a country which is able to be pioneering, ambitious, and confident. In 2020, we said as a nation, we will develop a pandemic vaccine within a year. This was led by our then Prime Minister Boris Johnson, who went and actually delivered on this. And actually, if you fast forward to 2023, the confidence of this nation is absolutely astounding. And you look at this BBC News, they plan for a national mRNA cancer vaccine advance. And the pictures you see here are actually, the one that I want to pick out is the bottom right, where what you're seeing here is a meeting where hundreds of oncologists are coming together to understand where the potential is, to get to grip with the technologies, a bit like what we're doing here, and to open trials across the system. This was announced in 2023, and I'm just going to fast forward to try and bring you up to speed of what's been happening over the last 2 years in this country, because it is very exciting, and it's where all countries should be. And when you've got clinical demand, patient communities which need treatment, and alignment across the board to try and pioneer a future medicine. Because it is not immediately obvious to me, and it wasn't immediately obvious to me in 2023, that what could happen for the world of infectious diseases can happen in the world of cancer too. And so what we're seeing now is a whole new research field open where you're seeing products being developed across many different types, and they're accelerating through product phases. So there's probably about hundreds of vaccines for cancer in phase 1, so that's looking at safety. At my last scope of clinicaltrials.gov, there are probably about 50 going through phase 2 studies, so that's looking for signal activity. So it's proof safety in about 20 patients. We're now into a couple of hundred patients, which is about 50 products. And actually, if you look at phase 3 studies, there's about 5 which are almost out the final stage of clinical development, 1,000 patient trials across the world. And actually, this surge of interest is absolutely fantastic, and it's taken the oncology community by storm because we want to see these benefits. We want to see the technology which is potentially safer, the one that patients want to see, and the ones which also might cause less side effects and may also be cheaper than cancer care. This all needs to be worked out, or to drive immunity against cancer. This is my checkerboard, the 12 most cancer types, most common cancer types. And when I look across the whole technology field across the world, the most amazing thing is cancer vaccine trials are now being run across many, many of them, including lung. And that's absolutely fantastic because cancer is not one disease, it's many different diseases, and therefore you probably do need to check your cancer vaccine across all of them. And that's what's happening across the board. Again, the clinical community started to pull together in the UK, talking about what we're going to achieve. And that's brilliant because actually what is fantastic about the NHS and how the UK system works is that you're not paid for by insurers. You're not worried about little regions or activities because we don't tend to think of our state, but we consist of 100 leading cancer centres all working together to try and pioneer what we believe is the greater thing that we can do in terms of our contribution to the future of medicine. And actually, the UK Cancer Advance is calling for three things, and it's actually delivering very effectively on them. Number one, get 10,000 people through trials by 2030. Yep, ticking that very quickly. Lots of people going through trials at the moment through the world's greatest clinical trialists in the UK, at our best trial centres, using the best scientific technology to achieve it. Two, we're definitely getting it across different subtypes. Lots of us have been engaging with industry. I know that London's been very good to get new trials in bladder and renal cancer. And actually Dundee's also just pulled through a esophageal gastric or gullet cancer trial into Scotland, which is brilliant. So we're doing this across many different subtypes. And the thing that we're trying to do now is really start to show UK leadership to stimulate technology advances across the world. We can do this alone, but actually all vaccine trials have to be global. And actually we do need other countries to pull very strongly here. And I'll talk about America because that's also very exciting. But you do see major nations starting to play their part too, like Spain and Poland and Australia trying to open trials too, to make this global effort. Because if we pull together across the world, we've done this before, you can get vaccine research going quicker. And actually, at the end of the day, we just got 3 phases of clinical trials before we know if the technology is good or not, how effective it is, and how much it could benefit patients. Just in terms of stats, I have to keep updating this, Eric, because more sites keep opening. And actually, the number of active vaccine cancer types gone up rapidly, well above this at the moment. And actually, the hundreds of patients, more like a couple hundreds of patients now. But I guess why I put this figure up is that actually every time a centre opens, and there's fantastic centres, the one that I'm most proud of is Devon in the south, because we have our leading research centres, the Christie, Royal Marsden, Oxford, Cambridge, Leeds and Liverpool. These are our fantastic recruiters. But actually, every so often something exciting happens, like when Hull or Devon open. Because they were want to be part of this. They're not big research centres, but they want to take part in vaccine trials. And they move heaven and earth to create research facilities and research opportunities for their patients in their region. These are centres which are maybe not the ones which pharma normally pick, but actually they also can do trials because they've got patients and they want to treat people and they want to pioneer scientific discoveries, and they form R&D committees and get going. And actually that is the collaborative spirit which allows research to go very, very fast, because it's just simply the spread of good ideas and the ambition of a doctor or nurse or trial centre who just want to achieve more. And that's what's absolutely phenomenal. So lots of sites opening, basically. If you look at the news at the moment, there is a lot of public interest. We've learned as a community that what with the vaccine hesitancy, you need to start communicating. And what's amazing is every time a trial site's open, they're talking to the local community through their press so that we don't have this hesitancy. Because they've seen the technology develop, they can see it's been done very carefully, they can see people monitoring side effects, they're looking for the efficacy. So actually, when this comes out the other side, which may be 2025 this year or 2026, the first approved trial, then actually you can see the scientific discovery and you can see actually we've done this with patient and public engagement. And actually, if you look at people like Adrian in the bottom right here, who had his treatment down in Liverpool by Prof. Christian Ostermeyers, Adrian wants to talk about this because he wants to see this through. And actually, this isn't about government or industry or doctors putting this onto patients. Patients want this too because it is a future and one that they can be part of too. Lot of press, basically. But this is really just awareness raising to make sure that people understand it's all being very, very thoroughly. But I do like the little bit in the bottom right, which talks about Britain in centre stage, because actually as a nation, we don't tend to be thought of like as, well, we were recognised as a world leading nation in terms of pandemic vaccine research. The question is, can we also talk a bit more about our achievement in terms of the cancer mRNA revolution. And actually, as a nation, we don't tend to champion our achievement, but cancer vaccine trials is very much where our country is one of the leaders around the world. But ignoring all this, we come back to what really matters now. And actually, if you look at what really matters, this is what matters. You've got people around the world, Elliot, Steve, Janus, and obviously Adrian too. They're faced with the most difficult situation, a cancer diagnosis, and they're thinking about how they want to help every other patient that comes after them. It's just absolutely wonderful. And these people all put themselves up to receive vaccines. And the most amazing thing is that what this allows is leading technology from providers around the world coming into their hospitals so they can get access to latest technology clinical trials. And they also contribute to every person after them in terms of learnings. This is what's amazing about clinical trials. And this is now an everyday reality in all the great research centres in the UK. They're pioneering this new treatment. It's wonderful. I mean, this changes, and actually listen to what some of these people say in terms of the press, and when they talk about their experiences and the effects on the families, and how this benefits the wider NHS because it builds a confidence that what they are doing is world changing. It puts the NHS back into the centre of being a discovery engine for the world in terms of technology. Right. Hard science now for 2 slides. Otherwise, Eric wants me to teach you. So let's go into the detail. Let's take the world-leading one of the trials, which is the furthest ahead at the moment. The trial is called Keynote 942. So I'm going to take you into more detail now. Stay with me. I won't take long. So I told you about personalized vaccines, where the vaccine is designed against the very genetic changes that cancer has. This is a trial for melanoma. And when you start in terms of trials, melanoma is a relatively easy one because we know that you can get hold of it because it's on the skin. It's very immunogenic. Immunotherapy works really well. This trial designed that personalized vaccine trial for that patient. So no 2 people in this trial got the same vaccine. Everyone is designed against their cancer and their immune markers. This is a phase 2 study. And what they did is they randomized people into standard of care, which is pembrolizumab, which works really well, and then standard of care plus a personalized immunotherapy, the red arm. What you're seeing on the graph on the right is a graph which shows 100% of people survive versus 0%, and this is time across the bottom. The blue bit shows people, unfortunately, as the cancer comes back, it recurs, they drop down. And you can see that about by this time point, 100 days, you're seeing 60% people have free from their cancer, but actually you know that about half the people's cancer will recur. In the red line is the people who've been getting the cancer vaccine too. And you can see actually the people where the cancer is coming back is happening at much lower rate. And that really shows the signal that this drug is working. It's not 100% effective, otherwise no one will have their cancer come back, but actually they're starting to see differences. You can ask me the question, why is it joined at the end? It's just because there's a small number of patients, so you can't call a signal actually, and therefore, but the lines are clearly going apart before that. What's the update from this? Well, this study was reported a few years ago. They had to do a phase 3 study. So now you've got to go from a small number of patients, 150, to thousands of patients. I guess the update in this is that the phase 3 study has recruited very, very quickly. I've been told from the clinicians who've been doing these trials that it recruited 1 year ahead of schedule. It's completed and it's now in monitoring mode. So the final phase of this study, the follow-up study, where you want even more data, has been completed. And the doctors are now all monitoring with the scientists to see actually what does that phase 3 look like. And it is possible to know by 2026 if this drug is definitely working, although we're definitely seeing signal from the earlier study. So really exciting. So I guess take-home messages are, in the disease subtype area, which is furthest ahead, melanoma, there are only 3 phases of clinical study for a personalized vaccine approach. It has already completed phase 3, and the world will know very shortly about how effective it was. And that could be the first regulatory approved cancer vaccine, which will be available. And if that happens in 2026, it would happen within 5 years of the pandemic vaccine. And that is very, very fast. Let me now bring you in now into the lung cancer world, because that is where Royal Brompton is world leading, and actually is an area which is interesting. And actually, again, you do see headlines like this, which is brilliant. World's first trial begins in Britain. Jab hope in fight against lung cancer. But let me try and put some more detail around this story, because it is true. Vaccines against lung cancer research is going very well. And Janos was one of the first patients, well, he was the first patient to get an mRNA vaccine against lung cancer. So this one trial that's going on at the moment. It is a phase 1. So bear in mind that phase 1 makes sure that we look for safety signals. We don't expect that many issues in terms of vaccines, in terms of safety issues, but it's important to do this. So this is a fixed vaccine. So I mentioned the melanoma as a personalized one, but this is a fixed vaccine, which means that everyone who's in this trial gets the same vaccine against these what we call tumor-associated antigens, abnormalities commonly seen in lung cancer. And they just get 6 doses. It's currently being trialed in people with advanced non-small cell lung cancer, which is the most common type of lung cancer. It's going through phase 1 studies at the moment. If you take a broader viewpoint about what other trials are there out there, look in the bottom left, that's my table, again from clinical trials, which shows that actually across the world, there are probably 4 trials that you need to be aware of. The one which is personalized neoantigen, which basically means each vaccine is designed for that patient based on what their lung cancer looks like. That's in phase 1 testing in an adjuvant setting, which basically means after Eric has cut the lung cancer out, people are being vaccinated at this stage. And you've obviously got the Luca-Merit and the Empower Lung Vax and Interpath, and all of them hopefully are going quite well. And actually, I went on to delve into which of the research centres in the UK are running these trials, and I've just listed them there too for a little shout out. So the ones I haven't shouted out is Imperial, UCL, Royal Marsden, Christie, Dundee, Oxford University Hospitals, Cardiff and London, GSTT and Newcastle. I guess why I'm shouting these people out, because it just makes me really happy that these great cancer centres want to be part of this, want to see advances happening, want to see technologies come to their patients, and they want to do it. And I guess the figure at the top makes me think about lung cancer as a whole, trying to put an idea of where things can happen, where we may see advances, where the trials are happening at the moment. So let me run through the flow chart at the top. People are diagnosed with lung cancer either through screening or symptomatic presentation. We're very lucky in the UK, we have a screening program, which is called the Lung Health Check, which allows people who've got a smoking history or at risk to have a scan of their lungs. Not every country's got that, and therefore other countries may be relying on symptomatic assessment. Once you've got the diagnosis, you try and split it into small cell versus non-small cell. Small cell is very aggressive, goes very quickly. There's probably no time for surgery for most people, and you probably don't want to do surgery anyway, unless you catch it very, very early. And their chemo is a mainstay, and chemo can be very effective in that situation. So that's one arm. But moving down the small cell arm, you can catch it at an early stage or late stage, depending on whether nodes were involved or depending on where spread. If you caught it early, you get a thoracic surgeon to cut it out and then think about giving treatment after it, either chemotherapy or a targeted therapy like osimertinib if it's an EGFR mutant. Conversely, if you catch it late, this is where it gets very complicated, and this is why I need so many medical oncologists in this space, because it's incredibly complicated how you treat people, because it depends on the genetic changes. But I will pull the opportunities here. If you're already sequencing the tumors to look for EGFR, ALK, ROS, to consider targeted therapy, all those grey boxes here, you've already got part of the solution here, the genetic sequencing. And actually, if you take the broader picture now, one day we need to think about where we're going to put cancer vaccines. Because we're already sequencing late stage tumors as either whether we can have targeted therapies or we go with chemotherapy and immunotherapy if they don't have drivers. But actually, the future is we need to think about where vaccines will go into this pipeline, because they're going through phase 1 studies to show efficacy. But let me just highlight potential areas where you might want to put vaccines into and where some of the trials are going. First thing, should you put it around the time of surgery, around early stage cancers? So I play this forward. You've picked up someone with cancer, you know it's not a small cell which needs chemotherapy. They're going to be lined up for surgery because Eric and his team want to chop it out. Should we be vaccinating that person there in the peri-operative stages here to try and either make surgery easier or to mop up any changes after surgery? That's the first question. The other question is, does it matter whether cancer is late or early stage? Should you, as soon as you've got a non-small cell diagnosis, put the cancer vaccine there around that MDT, because there's going to be a bit of time before you can get surgical slots, before you can get the medical oncologist in and chemotherapy slots, immunotherapy slots. Should you just be putting vaccine trials around that space? Third option is that, or maybe we should be putting vaccines around late stage cancers because we know it's spread outside the lungs, it's in the nodes. You're going to give them immunotherapy and unleash their immune system. Why don't you direct the immune system at the same time point to tell it what are the abnormalities seen in the cancer? Because the vaccine is effectively like giving the sniffer dog the scent of what the cancer looks like. It's just directing the immune system in that space. These are the four broad areas at the moment. But if you looked at, and these are areas of great research, and actually we need our trialists to come together in the industry to try and pioneer this. And the final bit will be the grand vision, which is what happens if you do all of this and you found out there's a vaccine which could be used as a preventative. That will be game changer if we ever get to that stage. So people potentially might be given vaccines at the age of 60 or 70 to prevent lung cancer, or 50. We're not at that stage yet. We need to work with cancer patients first, but as the technology moves forwards, you might get a preventive vaccine one day. And that is some research which is happening at the University of Oxford and beyond, and great centers around the world to see about preventive vaccines. So, final slide, Eric, almost on time. I would say that the future of medicine is here. If a single nation can unleash all these capabilities, that pace and that scale, and repeating what's happened in 2020, we should start 2025 very confident that we can deliver. And I was talking to Eric before we started about our centers opening trials quicker than ever before. We're showing great scientific leadership, championing new technology through, and the community coming together for the benefit of patients. And one of the things I was going to do, well, I was going to stop there and actually say we should do more of this. We should accept that trials should be able to happen within years and not decades. We should be opening trials as quickly as possible, getting centers to think about bringing technology in the world for research. And I put this final picture up because for those who are interested, go listen to what was said at the new president's inauguration in terms of cancer vaccines and how this may jump into the Stargate plan, which the Americans will may potentially join us in. It's all very exciting. And I would say this is a great start for 2025 because there's a confidence of what can be achieved together. Eric.
Thank you so much, Lennard. That's an amazing tour de force. And also, thank you very much for leading the country and getting this run through the NHS. I mean, a lot of this are also, your efforts are people like yourself bringing and leading the country forwards. Maybe we have time for just maybe two quick questions. I've got one quick question, which is, with regards to tumor heterogeneity, we expect the tumors to evolve with time. And if the cancer vaccines are based on the epitopes, which are sequenced at the time the vaccine is made, how do you think that we can actually, or is it possible to adapt the vaccines going forward for recurrent disease?
That's a great question, Eric. I think you're right. I mean, you can only treat the cancer which is there at that time point, and therefore many of the trials are starting when cancers are small, and therefore it hasn't evolved that much. Heterogeneity is an issue. I think you're kind of alluding to the point about the importance of rebiopsying, and I know that you already do quite a lot of that in the Brompton to go back in, if the tumors evolve, get another sample to see if the genetic changes have changed, and then opportunity may rise to think about should you then update your vaccine in that space. That's an area which I think is going to be a research field that could open in the future, but a great question.
We've got a question from Professor Paul Bass, who's asking about the likely cost of a personalized approach. I mean, what you've mentioned is pretty phenomenal, right? Vaccine advances, genomic advances, and AI advances for a personalized delivery. And to us, I think that's going to sound phenomenally expensive.
Yeah. And the most important thing we've got to think about is how do you make this equitable across the world too, and can we afford it? I mean, I guess I can't talk specific about cancer vaccines, but why don't we talk about how much that jab in the arm cost you and the nation back in 2020? It was a couple of £100, wasn't it? It wasn't very much because they were mass produced in these big mega factories, and all nations have invested in terms of manufacturing. So that upfront cost is gone because the factories are there. So what I'll probably say is that you can make vaccines for very, very cheap in terms of the mass produced fixed vaccines. There's going to be an additional step here about the sequencing and how much that costs. But bear in mind that sequencing costs drop every single year as the sequence technology advances. And therefore, this may not be as expensive as we think. And on top of that, bear in mind that cancer care at the moment is also very expensive and costly and hard to deliver. A vaccine is not, and that can be given in countries around the world. And many different developing countries around the world have been giving vaccines as part of their efforts to protect the population. The question is, can we get cancer vaccines through? Is it cheap enough to protect people across the world? And this is a transformative technology which could be globally accessible, again, if the cost is right.
Excellent. Thank you so much, Leonard, for such an informative talk. And obviously, once again, thanks to our sponsors, AstraZeneca, Medtronic, and Medilla, the Science of Care. Next week, we'll have Rudolph Hoover talking to us about terminology used in lung cancer screening. Once again, Leonard, thanks for leading the country. Thanks for educating us. And hopefully, we're going to continue leading the world in the lung cancer and other cancer vaccines.
Thank you, Eric.
Bye-bye.